Hello everyone. Once again, we would start the topic topography of the neck. Now, topography of the neck. Neck in Latin it is called as column. In Greek it is called as cervix, and in Russian it is called as shea. Now, in morphologically, the neck is unpaired between chest and head. Okay. Now, what are the borders of the neck? Inferior border of the head, which is superiorly. Inferiorly, jugular notch, superior margin of the clavicle, acromion of the scapula, imaginary line between the acromion and spinal process of the 7 cervical vertebrae. Now, this is the superior and inferior borders. Now, what are departments and borders? There are two departments, anterior department and posterior department. Now, between these and between the apex of mastoid process and acromion, or frontal plane passing through the transverse process of the cervical part of the vertebrae, or lateral margin of the trapezoid muscle. Now this neck, which is anterior and posterior department, there are triangles. How this triangle are divided? Like this triangle is divided by sternocleidomastoid muscle, which is coming as anterior and posterior. Now see, here is the mastoid process. Okay, this is the clavicle, this is the jugular notch. Now this is the sternocleidomastoid muscle, which divides this triangle into anterior and posterior. Now, because of the muscle attachments and this bones, there are several triangles are forming, which is submental triangle, which is formed by anterior belly of digastric muscle, hyoid bone, submandibular triangle, which is here, carotid triangle, omentotracheal triangle, omotrapezoid triangle, omoclavicular triangle, and Pirgov's triangle. We will study these triangles one by one. Now, anterior triangle. Anterior triangle is covered by skin, superficial fascia, platysma, and deep fascia. Now, this anterior triangle, what are the nerves which are innervated? Nerve are cervical branch of facial nerve and transverse cutaneous nerve. Okay. Now, what are the borders? Borders are sternocleidomastoid muscle, midline of the neck, and lower part of the mandible. What are the borders? Midline of the neck, which is anteriorly. Okay. Posteriorly is anterior border of sternocleidomastoid muscle. Posteriorly is anterior border of sternocleidomastoid muscle. Anterior border. And superiorly is lower margin of the body of mandible. Superiorly. Okay. Now this anterior triangle is divided by anterior and posterior belly of digastric muscle and superior belly of omohyoid muscle. Now in this diagram, check where is anterior border of anterior and posterior belly of digastric muscle. See, anterior belly of digastric muscle, posterior belly of digastric muscle, and superior belly of omohyoid muscle. Now this is anterior triangle. Okay. Now this anterior triangle is divided by this muscles, anterior belly, posterior belly of digastric muscle, and superior belly of omohyoid muscle. Now because of this, what are the triangles forming? Submental triangle, submandibular triangle, carotid triangle, and omotracheal triangle. Now submental triangle, see what are the borders. Posteriorly and inferiorly is hyoid bone. See, this first one is the submental triangle. Posteriorly and inferiorly also there is a hyoid bone, and laterally is anterior belly of digastric muscle. Submandibular triangle. What are the borders of submandibular triangle? Superiorly is mandibular base, and inferiorly is anterior and posterior belly of digastric muscle. It is very simple. In carotid triangle, this is the carotid triangle. Now borders of carotid triangle are medially there is superior belly of omohyoid muscle. See, we can see here. Superior belly of omohyoid muscle, it is medially. And laterally you can see what are those? Medial margin of sternocleidomastoid muscle. Laterally is medial margin of sternocleidomastoid muscle here. And superiorly is posterior belly of digastric muscle. Superiorly is posterior belly of digastric muscle. So three muscles are covering. Medially there is omohyoid muscle, laterally there is sternocleidomastoid muscle, and superiorly there is posterior belly of digastric muscle. Now next is omotracheal triangle. Borders of this omotracheal triangle is superolaterally. Superolaterally there is superior belly of omohyoid muscle. Medially, anterior median line of the neck here. And inferiorly, anterior border of sternocleidomastoid muscle. See, just try to remember the diagram. If you try to remember the diagram, it is very simple to notify the triangles and its borders. This is midline of neck. If this is midline of neck, this part, whatever is coming to this region, this side is medial. Okay. So according to this, first we need to know mastoid process to jugular notch. Sternocleidomastoid muscle is coming. Then hyoid bone, mastoid process and jugular notch. These three bones connect together and form the anterior triangle. Now this anterior triangle is divided by three muscles: anterior belly of digastric muscle, posterior belly of digastric muscle, and superior belly of omohyoid muscle. Now due to these three muscles, there are four triangles forming. Which are those? Submental triangle, submandibular, carotid triangle, omotracheal triangle. Now submental, posteriorly and inferiorly hyoid bone, laterally anterior belly of digastric muscle. Second is submandibular triangle. Submandibular triangle is superior inferior. Superiorly is mandible base, because through the name only we are getting submandible, means below the mandible. So superiorly there should be mandible base, and inferiorly there would be anterior and posterior belly of digastric muscle. Now third is carotid triangle. What are the borders of carotid triangle? Lateral, medial, superior. Carotid triangle medially. What is medially? Superior belly of omohyoid muscle. See, it is coming this side. According to this triangle, it is coming this side, right? So it is medial part. Superior belly of omohyoid muscle. Laterally is medial margin of sternocleidomastoid muscle. And superiorly is posterior belly of digastric muscle. Omotracheal triangle. Omotracheal triangle, first is midline. Anteriorly, like midline of neck. Superiolaterally is superior belly of omohyoid muscle, and inferiorly is anterior border of sternocleidomastoid muscle. That's it. So we will study in detail about this triangles. First one is submental triangle. Already we have learned the borders: posterior inferior hyoid bone, laterally is anterior belly of digastric muscle. Try to imagine the diagram, or else draw it once. If you have memorized it, draw it once, so it would be very easy to tell in the Viva exam without any confusion. Now what are the layers? Skin, superficial fascia, submental, lymph nodes. There are only three: skin, superficial fascia, submental, lymph nodes. That's it. Thin, skin is thin, sweat gland and sebaceous glands are present, and nerve. Now in this triangle, in these four triangles, keep remembering the layers. Everything you should remember, but in sequence, so that you shouldn't have any confusion. So keep the nerves properly. Remember the nerves properly, because there are similar nerves, only there is some superior inferior kind of difference. Submental triangle, the nerve is ramus superior nervi transverse coli. Okay. Superficial fascia is there is nothing into it, only the superficial fascia is present. Now there is submental lymph nodes. This submental lymph nodes drains lymph from tip of the tongue frontal teeth and gums, middle part of the inferior lip, and soft tissue of chin. The part near your oral cavity, tip of the tongue, frontal teeth and gums, middle part of the inferior lip, and soft tissue of the chin. It is very simple. Submental. It is below the mental. So it should drain from this part. Next is submandibular triangle. We already have studied the borders superior and inferior. Superiorly is mandible base, and inferiorly is anterior and posterior belly of digastric muscle. Now, what are the layers? In submandibular, the layers are skin, subcutaneous tissue, superficial fascia, proper fascia, and some fatty spaces are there. Now skin, it is same as submental triangle. What it is? Thin sweat and sebaceous glands are present, and nerve is ramus superior nervi transverse colli. In submental and submandibular, the nerve is ramus superior nervi transverse colli. Now, next is subcutaneous tissue. The subcutaneous tissue, there is skin and nerves, platysma muscle of facial expressions. Superficial fascia, there is fascia for skin, nerve, vessels and platysma. Proper fascia. Now, this proper fascia, it moves up to hyoid bone, and then it is divided into two laminas above the bone, which is superficial and deep lamina. Now, between the superficial and deep lamina of proper fascia, there is salivary gland. Okay, remember this. Where is salivary gland situated? When the proper fascia of what? Submandibular triangle, it moves to hyoid bone and then divides into two, superficial and deep lamina. Between these, there is salivary gland. Now there are fatty spaces. But what is there in this fatty space? Submandibular, salivary gland, lymph nodes, facial artery and vein, and fatty tissue. Now, deep lamina of the fascia covers what? Covers mylohyoid muscle. Lymph node is in this region, receives lymph from. Now, this deep lamina of the fascia, it covers mylohyoid muscle, but there are also lymph nodes in this region from where it collects the lymph. Superior lip, superior teeth gum, inferior angle of lower lip, lateral part and back of the tongue, lateral inferior teeth and gum. Now, just remember, when we studied in submental triangle, the submental lymph nodes, it collect lymph from where? Tip of the tongue, frontal teeth and gum, middle part of the inferior lip and soft tissue of the chin. And in submandibular, the deep lamina of the fascia, there is lymph node. Now this lymph node collects lymph from where? Superior lip, superior teeth gum, inferior angle of lower lip, lateral part and back of the tongue, and lateral inferior teeth and gums. Now whichever the part is remaining except this submental triangle, lymph nodes of submental triangle, all is included in this submandibular triangle. Fine. Now next is carotid triangle. Now borders we have already studied. Once again we would revise it. Medially, superior belly of omohyoid muscle. Laterally, medial margin of sternocleidomastoid muscle. And superiorly is posterior belly of digastric muscle. Now what are the layers? Layers are skin. Now in skin, in submental and submandibular, there was ramus superior nervi transverse colli. In submental and submandibular, ramus superior nervi transverse colli in skin. But in carotid triangle, inferior and superior branch of nervus transverse colli. Inferior and superior branches of nervus transverse colli is in carotid triangle skin. Now subcutaneous tissue, the skin nerve, external jugular vein and platysma muscle. In carotid triangle, in the subcutaneous tissue, the external jugular vein is present. Keep remember all these terms. In superficial fascia, covers arteries, veins and nerves. There is proper fascia and endocervical fascia also. Now, this endocervical fascia divides into lamina parietalis and lamina visceralis. Now in this lamina parietalis, there is internal jugular vein, common carotid artery and vagus nerve. Keep remember, in carotid triangle, subcutaneous tissue. Subcutaneous tissue consists of external jugular vein, and lamina parietalis, which is a division of endocervical fascia, it consists internal jugular vein, common carotid artery and vagus nerve. Now, next is omotracheal triangle. Omotracheal triangle, borders are superior laterally, superior belly of omohyoid muscle, medially anterior midline of neck, and inferiorly anterior border of sternocleidomastoid muscle. Now layers. Layers are skin, subcutaneous tissue, superficial fascia, proper fascia. In skin, there is inferior branch of nervus transverse colli. Now in submental and submandibular, there was ramus superior nervi transverse colli, means superior branch of transverse colli. But in carotid triangle, it was inferior and superior branch of nervus transverse colli. And omotracheal triangle, it is inferior branch of nervus transverse colli. Now in subcutaneous tissue, anterior jugular vein and platysma muscle is present. In carotid triangle, in subcutaneous tissue, external jugular vein is present. And in omotracheal triangle, subcutaneous tissue, anterior jugular vein is present. Now in superficial fascia, it covers the platysma muscle. Proper fascia, the superior part of this triangle. The proper fascia, what it does? In this triangle, omotracheal triangle, the superior part, it connects with deep fascia and forms linea alba colli. Okay. This is superior part of the triangle. But inferiorly, this proper fascia, it divides into two lamella. What are those? Proper fascia anterior to sternum and proper fascia posterior to the sternum. Fine. This posterior to the sternum, it is called deep fascia, and anterior to the sternum is called proper fascia. Now, between this anterior to the sternum and posterior to the sternum, which is also called as proper fascia and deep fascia, there is a triangular fatty space, which is called as spatum interaponeuroticum suprasternale. Now, these fatty space, there are fatty tissue, venous jugular arc and lymphatic nodes. And laterally to the sternocleidomastoid muscle, along the arc of jugular forms saccus retrosternocleidomastoid muscle, which is also called as herbus. Now next is deep fascia. After this proper fascia, there is deep fascia. This deep fascia covers several muscles, which are those: sternohyoid muscle, sternothyroid muscle, omohyoid muscle and thyrocervical muscle. Now next is endocervical fascia. Now in omotracheal triangle, endocervical fascia, it again divides into parietal and visceral. Now between these, there is again a fatty space. This is called as petium previscerale. Now in front of this, now this fatty space, in front of the trachea and larynx, it connects to anterior mediastinum. Now the visceral lamina, it covers which part? Cervical part of trachea, larynx, thyroid gland, parathyroid gland, esophagus and pharynx. Now we move on to the lateral triangle. Now lateral triangle, it is divided into omoclavicular triangle and omotrapezoid triangle. Fine. What are the borders of this triangle? Anteriorly, the posterior border of sternocleidomastoid muscle. Posteriorly, anterior border of trapezoid muscle. And inferiorly, middle 1/3 clavicle. Fine. Now, this triangle, it is covered by prevertebral layer of deep fascia. Fine. From like this deep fascia, it covers from above to downwards. What does it cover? Musculi semispinalis capitis, splenis capitis, levator scapula, and scalenus medius. Now, what are the contents of this lateral triangle? Which arteries does it carry? Subclavian artery, which is third part. Don't forget, when we would study the arteries, then I would tell there, this subclavian artery, third part, it comes under lateral triangle. Superficial cervical arteries, suprascapular artery, and occipital artery. What are the veins? External jugular vein and subclavian vein. Where does this external jugular vein comes? External jugular vein was there in carotid triangle, subcutaneous tissue. It consists of external jugular vein. Nerves, brachial plexus, spinal part of accessory nerve, and branches of cervical plexus. Now next is neurovascular bundles of the neck. Now these neurovascular bundles are mainly in the borders of the carotid triangle. With relation to this, medially is common carotid artery, laterally is internal jugular vein, and vagus nerve is between the common carotid artery and internal jugular vein. If we see how does it stands, this is medial part. So medially here is the common carotid artery. Okay. Laterally is internal jugular vein, and between this is vagus nerve. So if we say medial to lateral, artery, nerve, vein, common carotid artery, vagus nerve, internal jugular vein. Now next is classification of cervical fascia. This it is done by different scientists, and according to fascia, like how they have described, the coverings are also there. So I hope it is nothing to explain, because three scientists have told three different things. So I think it is better to read and if possible remember. It is nothing, whatever I have explained into this, superficial cervical fascia, superficial layer of Herb's fascia, whatever I have teached now, it is written. So please, if you can, pause the video and read it. I move on to the next topic, which is Vishnevsky vagosympathetic novocaine blockade. Now, why it is done? Trauma of the thorax, which is open or closed pneumothorax, combined injury of thorax and abdomen, or pulmectomy or heart transplant. Now what it is? To prevent pulmonary shock. The first aim to do this process is to prevent pulmonary shock. Why does Vishnevsky vagosympathetic novocaine blockade is done? To prevent pulmonary shock. Now how this pulmonary shock occurs? Because of what? Because of trauma of thorax, injury of thorax and abdomen, or heart transplant or pulmectomy. Now we move on to the procedure. How this procedure is done? First, the patient is slept on his back in supine position with a small pillow under the scapula. Now his head is turned opposite to the blockade, and hand on the side of the blockade is pulled down. If there is a blockade to my left side, then my head should be turned on the right, and left hand is pulled downward. Fine. Now, what should we see? There is a crossing point of sternocleidomastoid muscle and external jugular vein. We should check that crossing point. Then left index finger is pressed until the anterior surface of cervical vertebrae is felt and neurovascular bundles are displaced medially. Now just imagine what the surgeon is trying to do. On the neck, near the sternocleidomastoid muscle and external jugular vein, they check the crossing point. How this crossing point is seen? Because of this process. When the head is turned to one side, in the opposite side of blockade, and the hand is pulled down. We check the crossing point. Then the sternocleidomastoid muscle and external jugular vein. Then the left index finger is pressed until the anterior surface of cervical vertebrae is felt, and neurovascular bundles are there in this region, which are displaced medially. Now, next what should we do? Novocaine is introduced with a thin syringe of 2 gram, then 10 gram syringe of 0.25% Novocaine after making infiltrate when the tip reaches vertebra. We have shifted the neurovascular bundles medially. Fine. Now we are taking a syringe of 2 gram of Novocaine. We are putting a thin syringe into it. Then a 10 gram syringe of 0.25% Novocaine after making infiltrate. Means there is infiltration. Filtration is done of that region. Then when this syringe tip reaches the vertebra, pressure in the needle falls and surgeon must pull out the needle by 1 to 2 millimeter, and the blood is removed in the syringe for about 40 to 50 ml of 0.25% Novocaine solution. Now, solution is moved through the prevertebral fascia and contacts to the epineurium of the free nerve ending and sympathetic nerve, often free endings of sympathetic nerve and oftenly phrenic nerve. Then signs of correct manipulation includes. Now, what are the things which indications are there after this process? What are the indications? Hyperemia of the face and sclera. There is a Claude-Bernard-Horn syndrome. What it is? Miosis, which is pupil constriction, and ptosis, which is closed eyelid. Anophthalmos, which is falling of eyeball backward into the orbital cavity. Now this process, it is a very short and simple process which is called as Wisniewski-Vigo-sympathetic Novocaine blockade. Now there are some fatty spaces of the neck which are closed and open. Spatum parotoideum mastericum. Spatium hyomandibulare, spatum intraaponeuroticum suprasternale, spatium sternocleidomastoideum, spatium trapezoideum, and fatty space of floor of oral cavity. Which are the open? Spatium vasovenerum, periviscerale, retroviscerale, prevertebral, antascalenum, interscalenum, cellulosum trigonulum laterally. Now, there is a process of incision of phlegmons of the neck. If there is abscess and phlegmons of the neck, which can be superficial and deep, what is the procedure? If there is phlegmon of the submandibular region, which is then what should we do? Skin, subcutaneous tissue, and superficial fascia are dissected by scalpel along parallel margin of mandible. Deep structures are separated by the blunt instrument. What it is? Grooved probe. If there is phlegmon of floor of oral cavity, dissection from lower margin of mental protuberance to hyoid bone longitudinally. Mental protuberance to the hyoid bone longitudinally. Skin, subcutaneous tissue, superficial and deep fascia of neck are dissected. Deep structure by blunt instrument. What it is? Grooved probe to median raphe between mylohyoid muscle. Now, if there is phlegmon around large vessel, there is dissection on anterior and posterior margin of sternocleidomastoid muscle. Now, tissue below this is separated carefully to avoid neurovascular bundle damage. If there is a purulent process anterior to the lateral triangle, an incision is made on clavicle from posterior margin of sternocleidomastoid muscle parallel to the anterior margin of the trapezoid muscle. What it is done? See, I have explained you This is sternocleidomastoid muscle. This is midline of the neck. Here is the anterior triangle. Here is the lateral triangle. This is the sternocleidomastoid muscle. This is trapezoid muscle. Now, what it is saying? Anterior to the laterally. Fine. An incision is made on clavicle. Here was the clavicle. From posterior margin of sternocleidomastoid muscle. Here is the posterior. Wait, I will change the color. This is the posterior margin of sternocleidomastoid muscle. Parallel to the anterior margin of the trapezoid muscle. Parallel to the anterior margin of the trapezoid muscle. So, I hope so you have understood the structure, how it is done. That's why I said just remember the diagram, you would understand everything. Now, phlegmon of neurovascular bundle sheath is open widely with combination of dissection. Now, this is only for large vessels, phlegmon around the large vessels. What are those? Combination, Kuttner's and de Kernofen. Now, Kuttner is done in the superior part and de Kernofen is done in inferior part. Now, what is Kuttner's operation? First, we will do dissection of the skin, subcutaneous tissue, platysma muscle and superficial fascia. Now, from the mastoid process down along the anterior margin of the sternocleidomastoid muscle for about 1 to 1.5 centimeter, lower than the mastoid process, cutaneomuscular flap is separated from the vessels carefully and retracted. First, what we did, skin, subcutaneous tissue, platysma muscle and superficial fascia is dissected. Now, from the mastoid process downward along the anterior margin of the sternocleidomastoid muscle, approximately 1 to 1.5 centimeter, which is lower than the mastoid process. From here, cutaneomuscular flap is separated from the vessels carefully and retracted. Now, your accessory nerve is not damaged during this process. Now, a gauze is put under this flap. Which flap? Cutaneomuscular flap. After operative intervention on internal jugular vein. Now, what is de Kernoven's operation? In this, dissection of skin, subcutaneous tissue, platysma muscle and superficial fascia from the mastoid process along the anterior margin of sternocleidomastoid muscle. Until here, it is same as Kuttner's operation. But from here to clavicle and turn to horizontal direction parallel to the clavicle until anterior margin of trapezoid muscle forms a triangle. Fine. This is a change between Kuttner's operation and de Kernoven's operation. Now, covering from the sternocleidomastoid muscle is cut 2 to 3 cm above the clavicle after introducing of grooved probe anterior and posterior wall of the fascia. Now, between two ligatures, the external jugular vein is cut. Cutaneomuscular flap is divided from vessels and retracted, and two ligature made above and under the thrombus. Now, this was de Kernoven's operation. Now, this is only for phlegmon around the large vessels. What are those? Combination of dissection is done by Kuttner's operation and de Kernoven's operation. Now, we move on to the phlegmons of spatium previscerale. There is a transverse dissection through covering of neck, second and third layer of fascia, anterior muscle of the neck and parietal layer of fascia of the fourth layer. If there is injury to the larynx and trachea, then we should do tracheotomy. Now, phlegmons of spatium retroviscerale. Retrovisceral. Now, dissection is made similar to the approach to the esophagus. Patient head inclined forward prevents pus from the flowing into the respiratory tract. Now, in this diagram, there are different kinds of structures, like where is the phlegmon, where it is done abscess in the neck and phlegmons in the neck. Fine. We should study about this diagram so imaginary we can remember it properly. Now we move on to the next topic, which is topography of the larynx. Now, in topography of the larynx, morphologically there are 7 to 11 cartilage. Fine. This cartilage are divided into paired and unpaired. Now, what are those? Unpaired are thyroid cartilage, okay, epiglottic cartilage and cricoid cartilage. And paired are arytenoid cartilage, cuneiform cartilage, corniculate cartilage and treticaceae cartilage. Fine. The larynx consists three parts. What are those? Vestibulum, pars glottica, pars subglottica. Now pars glottica, it is between vocal plica and vestibular plica, and pars subglottica, it is present between from vestibular cord to trachea. Now what are the muscles of the larynx? Now according to the function, they move the cartilage and thus change the width of the cavity and width of the rima glottis. Now according to the function, they are divided into two: constrictor, dilator. Constrictor means doing constriction, narrowing the opening, and dilator means it is increasing the width of the opening. Which are those muscles which helps in constrictor? Thioarytenoid, transverse arytenoid, oblique arytenoid. And what are dilator? Posterior cricoarytenoid and thyroepiglottic muscle. Now, muscles which alter the density of the vocal ligament is cricothyroid and vocalis muscle. Now, which are the ligaments? Median and lateral thyrohyoid ligament. Median and lateral thyrohyoid ligament. Hyo and thyroepiglottic ligament. Hyoepiglottic ligament and thyroepiglottic ligament. Cricothyroid ligament, vocal ligament and vestibular ligament. Now what are the joints between in this larynx? Cricothyroid, cricoarytenoid, corniculate and arytenoid. What are the functions? Production of the voice and acting as a part of upper respiratory tract. Now, what is the holotopy of this? It is in the neck region and anterior department of the neck. Skeletopy is 4th to 6th cervical vertebrae. What is syntopy? Syntopy is anteriorly there is sternohyoid muscle, sternothyroid muscle, omohyoid muscle, cervical fascia, superficial part of lateral lobes of thyroid gland and perivisceral fatty space. These are anteriorly. Posteriorly, laryngeal part of pharynx and esophagus. Means, see, larynx is in front and behind is pharynx and esophagus. Superficially is hyoid bone and root of tongue. Inferiorly is trachea and laterally is omohyoid muscle, common carotid artery, vagus nerve, internal jugular vein. The neck part is very important because the neurovascular bundles is very important in this part, like common carotid artery, vagus nerve, internal jugular vein, external jugular vein, anterior part of jugular. So you need to keep remember all these things. Arterial supply and venous drainage. Superior and inferior laryngeal artery, superior and inferior laryngeal vein. Lymph node are vocal folds. Above and below, vocal fold above and below the vocal fold and above the vocal fold. Anterior superior group of deep cervical nodes and posterior inferior group of deep cervical nodes and prelaryngeal nodes. Now what is the nerve supply? Vestibulum and pars glottis. It is supplied by superior laryngeal nerve and pars subglottica is inferior laryngeal nerve. Now we move on to the next, which is topography of trachea. The trachea, there are difference in structure. How? Anterior 2/3, there is C-shaped cartilaginous ring, but posterior 1/3, there is no cartilage and made up of trachealis muscle and fibrous tissue. Holotopy is anterior department along the midline of the neck. Now what is the function? Air passage. Skeletopy. It is lower border of 6th cervical vertebrae and upper border of fifth thoracic vertebrae. See, I would correlate with another structure. This is larynx, right? Below the larynx, there is trachea. Fine. And what is the skeletopy? 4th to 6th cervical vertebrae. What is skeletopy of trachea? From 6th cervical, lower border of 6th cervical vertebrae to upper border of 5th thoracic vertebrae. Fine. Now, anteriorly, isthmus of thyroid gland. Posteriorly is esophagus, musculus longus colli, recurrent laryngeal nerve in tracheoesophageal groove. And bilaterally, lobes of thyroid gland, common carotid artery and carotid sheath. Now, arteries and veins. Inferior thyroid artery, inferior thyroid vein. Lymph are pretracheal and paratracheal node. Nerve is sympathetic and parasympathetic. What it is? Sensory for the mucous membrane and motor for trachealis muscle. Now we move on to the topography of pharynx. Pharynx morphologically, it is divided into 3 parts: nasopharynx, oropharynx, laryngopharynx. Now there is 6 types of tonsils which forms Pyrgov's lymphoepithelial ring. What it is? There are 2 types: paired, impaired. Paired is palatine tonsils and tubal tonsils. These are paired. And pharyngeal tonsil and lingual are unpaired. These are 6 tonsils which is called as Pyrgov's lymphoepithelial ring. Now what are the layers? Serous layer, serous layer, submucous layer, mucus and muscles are there. Now submucous layer, it is outer longitudinal, there are 3 elevators, and inner circular 3 constrictors. Muscles, 3 elevators, 3 constrictors. What are those? 3 elevators are palatopharyngeus, stylopharyngeus, salpingopharyngeus. Palato, stylo, salpingo. Palato, stylo, salpingo, pharyngeus. Fine. What are 3 constrictors? Superior, middle, inferior constrictor muscle. It is very simple. What are the function of this? Conducting food to the esophagus and conducting air to larynx and lungs. What is holotopy? Superior part, there is facial department. Inferior part in the neck. Now anteriorly, this was the holotopy. Skeletopy, base of the skull to the 7th cervical vertebrae. From the base of the skull to the 7th cervical vertebrae. Syntopy, superiorly is the base of the skull, inferiorly is the esophagus, anteriorly is nasal cavity, oral cavity, larynx, soft palate and epiglottis. Fine. Now posteriorly, there is upper part of the 6th cervical vertebrae, which is basilar part of the occipital bone also comes. Deep cervical vertebrae, deep cervical vertebral column, medulla oblongata, spinal cord and sympathetic trunk. Now what is laterally? Styloid process, common carotid artery, internal carotid artery, external carotid artery, accessory nerve, vagus nerve, hypoglossal nerve. Blood supply to this is ascending pharyngeal branch, which is of external carotid artery, ascending palatine and tonsil branch of facial artery and dorsal lingual branch of lingual artery. Then greater palatine, pharyngeal and pterygoid branch of maxillary artery. What is venous drainage? Internal jugular vein, facial vein. Lymphatic drainage is retropharyngeal lymph node, deep cervical lymph node. What is nerve supply? Nerve supply is pharyngeal branch of what? cranial accessory nerve, glossopharyngeal nerve, and superior cervical sympathetic ganglion. Then stylopharyngeus muscle, it is supplied by glossopharyngeal nerve. Now what is the stylopharyngeus muscle? It is stylopharyngeus muscle is elevator, which is outer longitudinally submuscular layer, outer longitudinally 3 elevator muscle stylopharyngeus, which is supplied by glossopharyngeal nerve. Inferior constrictor muscle is external and recurrent laryngeal nerve. Nasopharynx is maxillary nerve. Soft palate and tonsils is lesser palatine and glossopharyngeal nerve. Now facial nerve, which branch? Greater petrosal nerve, and lesser palatine nerve is a branch of pterygopalatine ganglion. Now next is topography of esophagus. Now esophagus, it is morphologically has 3 parts: cervical, thoracic and abdominal. Now what are the layers? Adventitious layer, muscular layer, external and internal. External is longitudinal fibers, internal is circular fibers. Then is submucous layer and mucous layer. Now there are 3 constrictions. Along the course of esophagus, there are 3 constrictions. First constriction is near the 6th cervical vertebrae, okay, which is mouth of the gullet. Next constriction is near the 5th thoracic vertebrae, where it is the thoracic vertebrae crossing the bronchi and aortic arch. See, 5th thoracic vertebrae, the crossing of aortic arch and bronchi is happening. Fine. Here is the second constriction. And third is at the 10th thoracic vertebrae. When it enters the hiatus esophagus into from the diaphragm, there is an opening called hiatus esophagus. When it enters, there is the third constriction. First is 6th cervical vertebrae. Second is 5th thoracic vertebrae. And third is 10th thoracic vertebrae. It is very simple. First is near the gullet, opening of the gullet. Second is bronchi and aortic arch crossing. And third is piercing into the diaphragm, hiatus esophagus. Now between these 2 constrictions, there are 2 dilations: superior dilation and inferior dilation. Now see, there is a deviation of esophagus. Superiorly, there is pectoral division is there. When there is a pectoral division of the superior part, it moves to the left side and immediately it moves to the right side. So left side first and then again immediately right side. Then at the 5th thoracic vertebrae, where there is second constriction, it moves to the left again. Okay, and then near the 10th thoracic vertebrae, it penetrates to the diaphragm. This is the deviation of the esophagus. Now what is the function? Conduction of food from the oral cavity to the stomach. What is a holotopy? Holotopy is cervical part, cervical cavity, thoracic part, pectoral cavity, posterior mediastinum covered slightly by pleura. And abdominal part is abdominal cavity covered by peritoneum. Now what is the skeletopy of this esophagus? From the 6th cervical vertebrae to the 11th thoracic vertebrae. Now we move on to the syntopy. According to the syntopy, the 3 parts which are divided: cervical part, thoracic and abdominal. We would see each part syntopy. Cervical part. Anteriorly, there is trachea, left lobe of thyroid gland and left recurrent nerve. Posteriorly, vertebral column and prevertebral fascia. Superiorly is pharynx and bilaterally is common carotid artery, internal jugular vein, vagus nerve and recurrent laryngeal nerve. Now remember, when there was first deviation, it moved to the left, right? then this is the cervical part which is moving to the left. So left lobe of the thyroid gland and left recurrent nerve. Remember, don't be confused, left or right. First deviation was to the left, so it is cervical part. So left lobe of thyroid gland and left recurrent nerve in the anteriorly. Next is syncope of the thoracic part. Thoracic part, anterior, posterior, bilateral. Thoracic part is also again divided into upper 1/3, middle 1/3 and lower 1/3. Now, according to this, anteriorly of upper 1/3 anteriorly, left recurrent laryngeal nerve, left common carotid artery, trachea, right tracheal part. Posteriorly is vertebral column and bilaterally is mediastinal pleura. Mediastinal pleura on the right side, like right side mediastinal pleura, thoracic duct and left subclavian artery which is on the left side. Now middle 1/3 of the thoracic part. Anteriorly is aortic arch, bifurcation of trachea, left bronchus and tracheobronchial plexus. Posteriorly is thoracic duct, prevertebral fatty tissue and azygous vein on the right side. Bilaterally is descending aorta on left and right vagus nerve on right. Lower 1/3 of the thoracic part, anteriorly is pericardium, heart, left vagus nerve with plexus. Posteriorly is thoracic aorta which is on right side, right vagus nerve and azygous vein. Bilaterally is upper pole of the spleen which is on the left side and left lobe of the liver which is on right side. Now next is the abdominal part. Abdominal part, inferior is stomach, anteriorly is peritoneum and left lobe of the liver. Posteriorly is the vertebral column and bilaterally there is upper pole of the spleen which is to the left and left lobe of the liver which is to the right. Now what are the arterial supply? For the cervical part, it is inferior thyroid artery, thoracic part, branches of the thoracic aorta, abdominal part, inferior phrenic artery and left gastric artery. Lymphatic drainage. Cervical part is paratracheal and inferior deep cervical nodes. Thoracic part is mediastinal lymph node and abdominal is left gastric and left inferior phrenic node. Now venous drainage is cervical part, brachiocephalic vein, thoracic part, azygous and hemiazygous vein and abdominal part, left gastric and left inferior phrenic vein. Now nerve supply. Nerve supply is vagus nerve, sympathetic trunk, splanchnic nerve and esophageal nerve. Topography of the thyroid gland. Now morphologically, structures are distinguished. What are those? Right lobe, left lobe, isthmus and pyramidal lobe. Now what is the function? It is an endocrine organ. Holotopy is anterior part of the neck. Skeletopy is fifth cervical vertebrae to the first thoracic vertebrae. Syncope is anteriorly sternothyroid muscle, sternohyoid muscle, superior belly of omohyoid muscle and external carotid artery. Posteriorly is pharynx, trachea, esophagus and parathyroid gland. Superiorly is thyroid and cricoid cartilage. Inferiorly is trachea, medially is cricothyroid muscle and laterally common carotid artery, internal jugular vein and vagus nerve. Arterial supply is superior thyroid artery which is a branch of external carotid artery, inferior thyroid artery which is a branch of thyrocervical artery, arterial thyroid ema from brachiocephalic trunk. Venous drainage is superior thyroid vein from internal which drains into internal jugular vein, inferior thyroid vein which drains into vena thyroidica ema which drains into the brachiocephalic vein. Lymphatic drainage is tracheal, deep cervical, mediastinal. Nerve is cervical ganglia from sympathetic trunk, medial and superior cervical part of vagus nerve, superior external recurrent laryngeal nerve. Now we move on to the surgery part of this organs. Conicotomy, which is a transverse dissection of cricothyroid ligament. If there is a foreign body at the level of cricoid cartilage which is closing to the respiratory tract, then we should do tracheostomy. Now, what should we do in this tracheostomy? Incision on trachea to gain the access to the airway below a blockage of foreign body or tumor. Indication is upper airway obstruction, lower airway protection against the aspiration of saliva, prolonged artificial respiration. Now, what is the aim for this tracheostomy? To relieve pain in the upper airway obstruction by tumor, foreign body, trauma or inflammatory swelling. Now, we should clear the secretion and prevent the tracheobronchial obstruction. We should maintain the prolonged artificial respiration and reduce the anatomical dead space. Now, what is the procedure of this? There is a pillow beneath the shoulders for hyperextension of the chin, which creates a midline. Then we should check the upper cricoid cartilage to the sternal notch. We should make an incision 2 inches, which is 5 centimeter vertically, midline incision. This incision should be of until deep fascia and opening of sternohyoid muscle. Now, the tracheal rings are exposed by transverse incision on endocervical fascia under the cricoid cartilage. Then we should dissect the trachea on second and third or third and fourth ring. Now, the tube is inserted as soon as the blood is drained. If there would be heavy bleeding, so the blood is drained and immediately a tube is inserted. But when we dissect a small incision here, the patient would cough due to entry of blood into the airway. Now a tube is inserted soon when the blood and secretions are sucked out. Next is the post-operative management. Now we should have a constant supervision and well ventilated warm room should be there. Now there are two tubes. One is cuffed tube and second is metal tube. Now for the cuffed tube, to release the regular and inflated pressure, which it is done to reduce the ischemic necrosis of the tracheal wall. And for the metal tube, to remove, clean and sterilize and replace the inner part as often it becomes blocked. Now, what are the advantages and disadvantages of this process? Advantages are, first is reduction of anatomical dead space, which decreases the work of breathing, increases the alveolar ventilation, decreases the sedation, and patient is able to talk and eat. Now, what are disadvantages? Thick mucus is formed which blocks the tube and loss of ciliated cells. What are the complications because of this? Hemorrhage, injury to the carotid artery or esophagus, damage to trachea, infection may spread, swallowing dysfunction may happen, tracheal stenosis may take place and tracheoesophageal fistula may occur. Now next is access to the esophagus. Indication is, if there is a bullet injury or wound, foreign body is there which creates obstruction or diverticulum occurs. What is the procedure? Patient should be in supine position, pillow under the shoulder and head turned to the right. When operation is on the left. Fine. Now, we give general anesthesia or local anesthesia. But we should avoid on recurrent laryngeal nerve. Now, we should do dissection of the skin, subcutaneous tissue, platysma and superficial fascia. Now, anterior margin of left sternocleidomastoid muscle. Now this is done from mastoid process to superior margin of the thyroid cartilage. Then the anterior covering of the sternocleidomastoid muscle is retracted. Now the third fascia of the neck is dissected. Then the common carotid artery, internal jugular vein and vagus nerve is retracted laterally. Then what we do? Omohyoid muscle is dissected. Then sternohyoid muscle, sternothyroid muscle, lateral lobe of the thyroid gland and trachea is retracted, not dissected. Only omohyoid muscle is dissected. All this, these two muscles and these two organs are retracted. And then esophagus is exposed. Now, the soft tissue is cleared with a blunt hook and left inferior thyroid artery is ligated and dissected. Now two ligature handle are applied and opened longitudinally until the mucous membrane. Then mucous membrane is held with clamp and dissected with scalpel. The foreign body, whichever it is removed. Then interrupted catgut sutures are applied throughout all the layers of the esophagus. Then external interrupted silk sutures. It is given to the muscular and adventitious layer of the esophagus. Again, this interrupted catgut suture are given to anterior and posterior wall of the muscles covering of sternocleidomastoid muscle, and silk suture is given on the skin. This was the complete procedure of access to the esophagus. Now next and the last is Nikolev's subtotal or subfacial resection of the thyroid gland. This is done because of diffused toxic goiter and tumor of the thyroid gland. What is the procedure? Supine position. Patient is in supine position with the pillow under the scapula. General anesthesia or local anesthesia is given. Then a collar shaped skin fold which is of 1 to 1.5 cm above the jugular notch and between the anterior margin of sternocleidomastoid muscle. Then dissection is done. Skin, subcutaneous tissue, platysma, superficial fascia is dissected. Superior flap is dissected until the base reaches the superior margin of thyroid cartilage. Then anterior jugular vein, which is in the second fascia, it is ligated and sutured. Then the second and third fascia is dissected longitudinally between the sternohyoid and sternothyroid muscle. There is a transverse dissection which is done in the sternohyoid muscle. Now, the sternothyroid is dissected in a large goiter. See, here transverse dissection is done in sternohyoid muscle, but sternothyroid is dissected when there is large goiter. Then Kocher's probe is introduced under the muscle and two clamps are applied to the muscle and is dissected and thyroid gland is seen. Now 10 ml of Novocaine which is given under the capsule of thyroid gland. Then Kocher's probe, it dissects the isthmus. If pyramidal lobe is present, then it is dissected prior to the operation. Operation means before dissecting this capsule. Fascia of the capsule is retracted and right lobe is dissected. Then the lower lobe and the upper lobe, it is displaced. Oh, sorry. Sorry, there was some glitch. I don't know, but the screen was gone. So let's continue. The lower lobe and then the upper lobe, it is displaced. First the lower lobe is displaced, then the upper lobe is displaced, and both are dissected. Then hemostasis with clamp, fascia of the capsule with catgut suture, Novocaine is processed to clean the toxic products, left lobe is also removed. Then sternohyoid muscle is sutured with a P-shaped catgut suture. Edge of the fascia with the interrupted catgut suture, and the skin is interrupted with interrupted silk suture. Then drainage tube is inserted into the wound for 1 day. Now this was complete process of Nikolev's subtotal and subfacial resection of the thyroid gland. Here we finish the topography and surgery of the neck. So keep watching, like, share and subscribe the channel and keep studying. If you have any doubt, please comment. Surely I would try to resolve it, and I would post many videos about not only about topographical anatomy but of other subjects also. So be active, keep studying. Bye bye.